Hello, good evening, and welcome. I am Dr. Thomas Allen, Chair of the Oversight Committee for Physician Health of the Maryland Board of Trustees for the Center for Healthy Maryland. 2023 marks the 45th anniversary of the founding of the Maryland Physician Health Program. It's our anniversary. It's a big one. The program's mission is to provide compassionate, high-quality assistance to physicians and other healthcare professionals dealing with potentially impairing conditions in a private, non-disciplinary setting while protecting both the confidentiality of the participant and the safety of the public. I am pleased to launch tonight's edition of our 45th anniversary ongoing lecture series, Lemons to Lemonade, Harnessing Our Strengths in Difficult Times. The program is sponsoring a series of lectures and events throughout the year, so be sure to check for updates in the meetings and events section of the Center for Healthy Maryland's website at healthymaryland.org. And while you are there, consider hitting the donate button and help continue and expand the program valuable services to the Maryland community of medicine. Now I'd like to turn the microphone over to one of the program's medical directors, Dr. Martin Rusinowitz, who will introduce you to tonight's speaker on the topic of great importance, physician burnout. Dr. Rusinowitz.
Thanks, Tom. Thanks. Just a little bit about Brooke. She's a board-certified general surgeon and a diplomat of the American Board of Surgery, as well as lifestyle medicine. She currently serves, after having left Maryland, and as Chief Medical Officer of Henry Ford's Wyandotte Hospital and Vice Chief of Medical Affairs for Henry Ford Health in Detroit. I must say I trained in Detroit, and it's a massive institution. Big job. Prior roles include Vice President and Chief of Medical Officer Emeritus, as well as Associate Chair of Surgery and Medical Director for both the acute care surgery and wound centers at Anne Arundel Medical Center in Annapolis. She's a longtime member of the American Medical Association and currently secretary of the American Medical Political Action Committee. Brooke graduated from Ohio State University College of Medicine and Public Health in Columbus, Ohio, completed internships in surgical residency and general surgery at Fairview Hospital at the Cleveland Clinic. She has 3 sons, Jack 9, Kobe 7, and Finch 7. More importantly to me, on a personal note, was a thank you note I received from Brooke years ago after I'd spoken at a physician burnout conference at the medical center organized by her. It was unique in that it was a handwritten note, so very special, uncommon, and meaningful. I continue to remember it and have it in my desk. I'll never forget it. So, Dr. Buckley, thanks.
Thank you so much. Wow. My mom just walked out of the room. I should bring her back in. Well, no, she raised me right. Thank you so much for the kind welcome. And it's so great, albeit virtually, to be back in Maryland, and not just a little bit intimidating to be speaking to colleagues, friends, and most importantly, mentors of mine for much of my career. So thank you so much for allowing me to share some of my thoughts tonight on physicians, leadership, and most importantly, leading in a burned out world. I'm going to go ahead and share my screen. I think the ask has been to save the questions towards the end. You can put them in the chat, and hopefully you all can see my presentation. You can put your questions in the chat and or raise your virtual hand, and we will moderate the questions as we go. But if they can save to the end, that's great too. All right. Can I get a thumbs up, Dr. Allen, that you can see my screen? Yes. Okay, perfect. Thank you. You're the picture that I can see. All righty. So without further ado, we will go ahead and get started. So I just added a little bio slide. Thank you so much for the warm introduction. And I'll just say that telling our stories is incredibly important, and it's something that many of us are reluctant to do. And so I share with you that there's a certain art into sharing the right things at the right time into the right audience, and it's one that I'm still learning. but it's one that I think is just really thoughtful and important to get those details right. Because, for example, I'm actually chair of AMPAC currently, and the first female chair in 60 years of the organization. Apparently I sent the previous version of my bio. So the objectives tonight that we published and talked about was really to sort of discuss a little bit about physician leadership. I want to share some thoughts that I have, maybe somewhat non-traditional, on what is physician leadership and when are we invoked and called to lead. We'll go over some of the environmental challenges, those that we all know well, but I'd like to apply some definitions and maybe cross-fertilize a little bit in between the different ways that we talk about what's going on in our workforce and our world. We'll talk about the physiologic effects on physicians and team as it relates to this burnout, chronic stress. We'll also look at individual and workplace emotional safety. And then finally, circle back to how can I, as a single person, as a single agent, as a physician, create some trauma-informed workspace, but safety and predictability in my workspace. And I use workspace kind of loosely because many of us, or all of us, have different settings in which we do our work, and we'll talk a little bit and define that a little bit further. But I'd like for everybody to kind of get in sort of their broadest mindset in terms of, this doesn't mean the hospital. It doesn't necessarily mean your office. It may mean your community or your family, or even in the room with a single patient. It may actually be in quiet conversation with yourself, where you create these workspaces that are safe and cognizant of the trauma that we've all been through. So first off, as promised, we'll talk about physicians as leaders. This is something that I think throughout my career, when we talk about physician leadership, we often think of the chair of the department, the chief of staff, the CMO, those kinds of things. But I would like to submit that we are leaders just by virtue of being physicians. But the sort of traditional path that we go through to think about leadership is, do I want to be this type of leader? We think about departments, we think about having to be available and affable, being a resource. Oftentimes you have to say yes way more than you say no. We talk about county, state, and national specialty societies as a Center for Healthy Maryland and a MedChi branch. We're all people who are probably more involved with our organizations than some of our colleagues, but that's sort of a traditional place that we think about leading. Of course, we think about in hospitals. Sometimes we think about startups and tech, government, in other places, but that sort of non-traditional thinking is an opportunity for us. The questions that we also often will ask ourselves are really just sort of putting framework around, what do I think of when I think of physician leadership? We think about where, we think about our timelines, we think about what training we might need. We should be thinking about, what can I control in that space? So oftentimes we gravitate towards leadership that feels like a positive attitude, that has humility, someone who is able to manage their ego. Those are the leaders that we tend to gravitate towards. And then we think about specific efforts like advocacy, lobbying, networking, and fundraising, and others. And again, because many people either screenshot these slides or ask for the recording, those kinds of things, I just put down thoughts that people can refer to later, and I'm happy to share the slides. This is really where I want to kind of pivot. So physician leadership is literally every time we are in communion with someone else. When we walk into a room with a patient, when we walk into the room with a nurse, our front desk, people are looking to us to lead. And I've often said, when I've taught residents and medical students, they're looking to us to lead from the day we say we want to be a doctor. The part of the work of being a physician is being a leader in our communities. Whether we choose to carry that mantle or not, it's part of who we are and part of who the people around us see. So I wanted to give you a definition that I think really resonates, which is that leadership is words or actions influencing behavior, whether that is formal or informal. And hopefully that's starting to make sense and resonate right now. So when we think about positive leaders, it's very easy to connect leadership to that person. When we think about negative leaders or leaders that are polarizing, the things that cause that polarization, whether it's how they show up, how they act, words that they use, actions that they provoke out of others, for better or for worse, that is leadership. And when you can command a group of people, a room of people, a nation of people, you are leading. And it doesn't have to be positive, but obviously the goal of this conversation is really around what does positive leadership look like. So I would urge us to consider, we have family members that are constantly calling, right, for suggestions and information about what's going on with their health. That's a call to leadership, right? That's a call to safety and security. Whether you're on the sidelines with your family, your children, your grandchildren, if you're in your community at an art fair and there's a medical emergency, if you're in a small community and people just recognize you at the Lowe's because you did their surgery or delivered their baby, that's a call for leadership. And I put these faces here because I think that when we are in our workspaces and we get these looks, we can recognize that there's an opportunity maybe for better positive leadership in these moments. And so that really is kind of the meat of this conversation today, is to look into how can I show up as my best leader? And maybe even more importantly, how can I recognize when my leadership is falling short? And then the tools to sort of manage how we show up in these spaces. So I wanted to define a little bit further. I think trying to put myself in the position of different people who call us to be leaders, patients often are scared and they need to feel safe. They want to feel safe and they deserve an expert healthcare partner. Our team may also be scared. Quite frankly, we may be scared. And they want us to know that they are here to help people as well. They want the best outcomes just like we do. And they're likely looking for us to lead. Personally, I think when we think about leadership, we really consider that we've worked incredibly hard to become doctors. We want to be respected and we all want to improve the health of our communities. So even when we're not necessarily showing up as our best selves, I think these are often core identities that we share. And recognizing that the community is designed with the help and input of architecture of experts in the field, meaning that we are part of the design of our community. We are part of what grows and shapes the community around us. And I think especially coming out of COVID, and I'll say one of the gifts of being at Henry Ford in Detroit, recognizing and acknowledging, I think Meritus is doing this incredibly well as well, that the people around us, the teachers, the people in faith circles, the people in small businesses, everyone is relying on a healthy community to serve the community, to grow the community. And the physicians really are that nidus that helps to grow that. And if we take seriously our commitment to our communities can flourish. And if we abandon our communities in fact likely will not flourish without us. So that's a really beautiful story to tell. And we all know that the practical realities of this are not quite so flowery. So let's just go ahead and dive right into some of the environmental challenges, the stress, distress, and violence that we are currently facing. So pathologic workplace stress. I think stress is normal. We all experience it. It's part of the human condition. But pathologic is when normal circumstances become exaggerated or unmitigated to an extent that they drive social or physiologic derangement. That for me is really the underpinning definition. And whether we talk about toxic stress, burnout, moral injury, trauma, all of these types of words that we've used to give this a name, it is a pathology of stress that has gone to a place that is changing the way we engage each other, either because of our own chemistry or the chemistry of the relationships around us. Workplace violence, which has always been there, I think it was in as early as the 1800s where there are published articles related to workplace violence. It is certainly top of mind right now. The definition by the World Health Organization of workplace violence is incidents where staff are abused, threatened, or assaulted in circumstances related to their work, including commuting to and from work, involving an explicit or implicit challenge to their safety, well-being, or health. And I actually tried to Google in relation to some recent really tragic events. And an article that came out in the early 2000s in Italy suggested that over 30 Italian physicians had been killed in the line of duty, either in their workplace or their home as it related to a relationship with a patient, had been directly killed because they were a physician in relationship with that patient. And that number just really, it was staggering, I think. I mean, Italy is not as big of a country as America. This was pre-COVID. And so it's just to really put a highlight on, we are reporting these things, we are recognizing these things, the world is changing, and we're not as different sometimes as we think we are, and that this underpinnings for this have been going on for a very long time. And I say that really as a call for each of us in our own environments to try to dig into understanding and to try to help mitigate some of the causes of the violence. And then I've really attached recently in the last 3 to 5 years around trauma and trying to understand trauma. And many of us as docs and certainly as surgeons think of trauma as purely physical. But those of you that are psychiatrists and family docs and maybe just more in tune than I was several years ago will understand that trauma is also very much emotional. And Gabor Mate, who is a family physician in Canada, and Bessel van der Kolk are two incredible physician authors on the topic of trauma. So I've included these books, and I'll have a bibliography at the end as places people can look for resources. But Gabor Mate will say trauma is not what happened to you, but what happened inside of you. Again, disassociating from that it's something that you caused or created. It's something that happens, that actually physically changes inside of you when these things occur. He says that trauma is a psychic wound that hardens you psychologically and then interferes with your ability to grow and develop. And that growth and development, especially as we transition post-pandemic, growth doesn't just have to be from 5 to 15 years old or something chronologic. Growth can really be about our psychological state and where we live and comport ourselves in our daily work. And then I love this by van der Kolk, which is trauma is specifically an event that overwhelms the central nervous system, altering the way we process and recall memories. Trauma is not the story of something that happened back then, he adds. It's the current imprint of that pain, horror, and fear living inside of people. So it's really a story of, we've all been through a lot of things. Some of those are little t traumas, that they are small and maybe not even noticeable to other people. And some of those are capital T, national, international crises type traumas. And all of those things in a state that is stuck in that trauma brings everything back to the forefront immediately. So even things as simple as things that happen to us in residency that inform the way we treat nurses and residents now is part of the story that we have to unpack and unwind if we want to show up as our best selves. So I share this as well for those of you that aren't as aware of this work, because I think it's emerging, especially amongst physicians who are not directly involved with this. It wasn't something that certainly that I was taught in medical school, but there are spheres of trauma where it can happen directly to yourself, which totally makes sense. There's intergenerational where you pass that work and that reaction, that reactivity down to family members. So when you think to yourself, I'm acting like my mother or my father, those are the types of behaviors when they are negative that may be related to intergenerational trauma. Collective trauma is how it happens in your community. So how an entire community might respond to something that they've experienced. So if you think about the people, for instance, that were in New York on September 11th versus maybe people that were in Iowa, right? There might be a different response pattern based on your proximity to a traumatic event or traumatic spaces. And then there's historical and cultural trauma, which of course is that my people, the culture, the race, the group that I identify with, over time have received this trauma. And so they all sort of fold in on each other. And each of us can have experienced any one of these four, and they can cross over with different people at different times. And that's part of the power of affinity groups. It's part of the power of community. And it is part of the opportunity collectively as a profession to reach into each other. The intimacy of attending to the lives and deaths of other people is a incredibly special bond that we all share, regardless of whether we are in family medicine, orthopedic surgery, or administration. And I think it's a real opportunity as we're in what I would call a bit of an existential crisis in medicine in terms of who are we in 10 years? Do we need to build more doctors? Do we need to shrink down less doctors and give up more scope of practice? What is artificial intelligence and telemedicine going to do to the intimacy of our art? do people actually trust us? And as we age and need our own doctors, who are we going to turn to, and how do we know if we can trust them? All these types of questions require us in conversation with each other around our stories and around what we've been through and how we've learned to manage and grow past that. And just for some statistics, I want to be able to share, the trauma is a really big deal. And it's about a 15 times more likelihood of suicide with traumatic events, more likely to smoke, drink alcohol, inject drugs. You're more likely to be absent from work, to use antidepressant medication, and to experience depression at all. So I think some of these are fairly obvious, but these are all, again, sort of that pathology behavior where you go from being able to function in a healthy way to a way that is requires soothing, it requires props and other interventions to try to behave normally. And certainly the worst of that is someone who would be compelled to take their own life based on their ability or inability to manage the trauma that they've experienced. So really, to just sort of put a point on this, 62% of physicians are burned out. Burnout comes from a collective group of unmitigated stress or traumas. 50% of healthcare workers experience violence in their career. I think that number is actually higher, but that's how it's reported. 70% of adults have had more than one traumatic event. And for those of you familiar with the ACEs evaluation of younger children, the numbers are pretty staggering, the percentage of people who have had 2 and 3 traumatic events in their lifetime. So it's additive, but 70% of us, all comers, men, women, any race, have had at least one traumatic event. So none of us are immune to what I'm about to share today. And so I just invite us all into this conversation in the places that connect us, more so than the places that tear us apart. Only 13% of docs, as published, seek mental health treatment, and 87% of us say that they're not comfortable seeking help. Certainly, the Physicians Health Program has done a lot of work trying to take down some of that stigma, trying to create safe spaces. Maryland is absolutely one of the forerunners in the country on the MPHP program, and I've been honored to be part of the board and part of that work for many years now. And so Maryland is incredibly blessed with huge, safe resources to seek help. Most importantly, to help physicians and other providers stay active in their practice as they heal from the difficult things that they are struggling with. So physiology. So what does it actually do to us? And I am certainly not a neurochemist, a neurobiologist, or any of these things. So I'm going to give this to us in a fairly non-medicine-y kind of way. Because at this point, we're all patients of this as opposed to doctors in this, is how I'd like to think of it. So Bruce Perry wrote a really cool book with Oprah Winfrey that's been getting a lot of publicity, and it's a great tool to help introduce this in a kind of gentle, non-medicine-y way to people, and I think people that are resistant, which may be ourselves and our colleagues, to this whole concept. But what he really reminds us of is that the brain and the way that we think and the way that we react is stacked from a brainstem, very basic fight or flight type reactivity, to the midbrain, to the limbic, to the cortical. And as you go up those layers of the brain, which I hazily remember from medical school, you get closer and closer to executive functioning. So at the brainstem, which is our so-called critter brain or reptilian brain, it is basically about keeping yourself alive. It's your heart rate, it's your breathing rate, it's how your blood moves through your body. At the cortex, it's self-control, management, empathy. It's where leadership comes from. It's where executive functioning, as they call it, comes from. And so the easy, simple way to really think about this, and again, I've got the cover of the book down there in the corner, is that the cortex, that most executive function, helps us to reason. It helps us to really be thoughtful and empathetic as we deal with each other and ourselves. That limbic and diencephalon, kind of in the middle, is sort of how we relate to each other in a little bit more of a primitive kind of automatic style. And the brainstem is really how we regulate ourselves. So, am I cold? Do I need to run? Do I need to sleep? And so as we think about how we can regulate our environments and ourselves as it relates to our reactions, it's helpful sometimes to think about, where in my brain am I, right? Am I just so irritated with my late cases and my canceled this and how anesthesia is treating me and how I got scheduled and the fact that the school bus didn't come on time today, that I am like fully in brainstem mode and just trying to breathe and keep my heart rate under control so I don't pass out because I'm so frustrated? Or am I showing up to this completely chaotic exercise able to reason and rationalize and put myself in other people's shoes and understand why they may be acting in ways that are not necessarily showing up as their best self, right? And so the goal of leadership, the goal of being present as our best selves, is to find more and more ways to be able to show up in our cortex, in our reasoning, in our executive functioning. And that's not to say that it's perfect, and it's not to say that it's 100% of the time, because we're human. And so we do spend time in our brainstem, and recognizing that time, recognizing where I'm just so out of control, I need a timeout, I need to take a breath, I need to go in the corner and just breathe for a minute, is a really important way to prevent the harm that happens from passing that trauma along. I liked this. It's kind of oversimplified, but again, just really trying to drive home the point. When you are overstimulated, dysregulation is knocking at the door. So when there's noise and there's, physical irritation, it's too hot, it's too cold, you're emotionally disrupted because of what's going on at home, what's going on in your office, trying to manage your call and your pager, too many Halo or Tiger texts, those kinds of things. The more disruptions, the more drops coming into your cup, the more likely that you're going to feel out of control. And again, recognizing it first, and then figuring out how to regulate it in your own space, in your own environment, in your own personality, are our opportunities. And then I just really wanted to show you this around sort of the phases and the regulation, the cycle, if you will, of burnout. I don't think this is a widely used construct, but as I constantly am searching Google for other people's thought leadership on these things, I think we could really relate to this, right? In the beginning, you feel really excited and energized. You raise your hands for a lot of stuff. And whether it's the beginning of your career or the beginning of a cycle of burnout, there's just a lot of volunteerism, right? And then as you do that, you often don't set boundaries that are helpful. And so you've raised your hand for too many things. You've gotten engaged in too many things. And then into the next phase, you start to pull back. And so it isn't necessarily a rational pullback. It's like, I'm just going to cancel the night before. I'm just not going to show up to this event that I said I was going to go to because I'm just too darn tired. I'm too frustrated and I can't do it. And then in the last phase, after you've pulled back enough and your body starts to restore, you start feeling kind of okay again. And then you start raising your hand again, right? So we kind of do this all the time. And whether it's full on, burnout and toxic stress and moral injury, or whether it's just sort of what we do, it's all a journey, it's all a continuum. But what I will offer is, if we space out or scope out to the broadest understanding of our profession, as physicians, we come into this profession, we came into this profession, Hippocrates style, we're going to save people and help people. We have extended ourselves into all of the reaches of public health, all of the reaches of social justice and equity, all of the reaches of curing cancer and stopping death and massive trauma and war. And we are overwhelmed as a profession, right? We are trying to manage conversations around prior authorization, around communication, around scope of practice, around what is happening with electronic medical records and others. But it is so far out of the barn that many, many people are pulling way back, right? They're retiring early, they're canceling their practices, they're going only into concierge and not treating the patients they want to treat, but treating the patients that they can find a path to treat without losing their own sanity. And I would submit that we're kind of at a little bit of a nadir here in terms of how bad it can get. Or at least if we recognize the opportunity to start to step back into places that make sense for physicians, start to recognize where it doesn't make sense for us to be fighting those battles. And some of that's going to be personal, some of that's going to be our work through organized medicine, and some of that's going to be profession related. But I think kind of naming it, recognizing it, what's too much, what are my boundaries, what can I accomplish, is really, really important. And I will say that one of my breast surgeons in my residency, who worked in a small clinic, part of the community arm of the Cleveland Clinic, said that what she understood about our profession is that if you choose your corner of the universe, and whether that's a one-stoplight town, an entire country, or the entire globe, and you do the very best you can to serve that corner, that you will be happy in medicine. And so again, just understanding what your community is, what your commitment is for your personal self will really help to set a framework that has more successes than failures as we go through our journeys. So pivoting once again to individual and workplace emotional safety, right? All well and good, great. We've named it, we've given it titles and definitions, but every day I go to work and I just get completely overwhelmed, and I come home completely exhausted and frustrated with my family, my dog, and then I fall asleep for a minute and I go back and I do it again, right? Like the rat wheel just doesn't slow down. So connecting the dots, to make this really explicit, the distress reactions from the frustration turn into burnout, right? So all the things that we feel, the frustration, the anger, the irritation, which I think we can all relate to, eventually turns out into burnout, moral injury, toxic stress, whatever word you want to use. As Tate Shanafelt and others have really delineated, that's that emotional exhaustion, the depersonalization, where I don't care anymore, and pour out, I did not write Jube's satisfaction, but somebody got all the words all messed up and I couldn't edit them. And if it goes too far, right, if we're not able to mitigate and manage it, it goes into potentially various disorders that we, as I've shared, are resistant to seeking help for various really important reasons, like, will I lose my license? Will people not believe and trust in me anymore? The sense that I have to be some kind of superhuman and not seek help for what is a really obvious reason for why I'm not able to regulate myself in a way that is healthy. And by the way, generationally, and passing that on to the doctors that I train, and community-wise, and passing that on to the patients and the people that try to work with me, because my reactions are not in my cognitive functioning. They're somewhere down here in my brainstem, and I'm sharing that and spreading that disease, if you will, with everyone around me. And we see that in some of our behaviors. And this has smoking and alcohol, et cetera, but it can just be my hyper reactivity and the meanness and the curtness with which I treat the people around me, which ultimately obviously informs how people feel about doctors and healthcare spaces and whether or not people feel safe around us. The most important thing we can do for people is to help them feel safe. In this article by Tate Shanafelt, which for me has been one of the most important single tools to use with your staff, with your medical executive committee, with your CEO of your hospital, because it's very tactical and kind of operationally set up like a business. He describes on the professional side, on the personal side, the things that happen when we aren't our best self. We've talked about this repeatedly, but he also describes on the professional side, things that happen are errors, decreased patient satisfaction, decreased productivity and professional effort. So decreased days at work, which equals less doctors to serve people, and increased turnover. All of these things on the right are costly to businesses. It makes it harder to be a thriving hospital, a thriving system, a thriving business. If you're in private practice and you are doing all of the stress and burnout things personally, the turnover in your staff, the willingness to work with you and for you, the extra effort that it requires to get prior auth and all these other nuisances through, all those things decrease, which makes your work even harder, which threatens your business even more. So just really wanting us to appreciate it's all connected, and it feels gigantic and overwhelming. And in some respects it is, but as we circle through the burnout cycle I have a little bit more bandwidth to think about this, there are opportunities to pull some levers to change our future. And this is just to really tie a bow on organizational trauma looks like breakdown in communication, breakdown in trust and productivity, people feeling powerless. You'll see that in the employee engagement surveys where people don't feel engaged. It's a so-called best friend at work question. People feel hopeless. They start changing their roles and responsibilities, and they feel just gigantic loss over the autonomy and the purpose in their jobs. And I think we can all relate to that. And I put these pictures in there just in terms of like the body posturing, right? This doesn't have to be on some grand global scale. It can be in our very tiny, intimate moments where you realize that we're just disconnected as people. disconnected from our profession and our mission. And so really, what can we do to get that back? When I put these 4 faces here, I am guessing that most of us are aware of these physicians, but this is as bad as it gets. We know that about 400 people a year, physicians a year, take their own lives by suicide. Lorna Breen took her life in early COVID because of overwhelm. And as the story goes, was one of us who was resistant to seeking care when it was most necessary to help her manage herself through COVID. And her family has really set off on a mission to try to help healthcare providers, specifically physicians, to deal with the burnout crisis. There's so many people working on this, and it's a gigantically enormous project, obviously. Preston Phillips and Stephanie Hewson were physicians murdered in their workplace in Texas. And just last week, Benjamin Mauk was murdered in his workplace in a patient room with a patient and a nurse. The patient killed him, did not harm the nurse, and walked out of the clinic. And the patient had been in the clinic for apparently some period of time before doing this. So very targeted attacks on physicians. Oftentimes, these circle back to pain medications. They circle back to really incredible problems that patients are dealing with on their own. But our fear and our concern and our frustration and being driven into that brainstem type functioning, it's real. It's coming from real reasons. We have reasons to be afraid. We have reasons to be frustrated and angry. And we are being called on to be the leaders, to walk ourselves, our profession, our communities out of this space. And quite frankly, as physicians, we have access to every human on the planet that has the ability to get to us, right? We all will run into a physician at some point in our life through healthcare. And so we have the opportunity to touch literally everyone to try to spread the message of a healthier and more self-aware space. So what do I do about my workspace? What do I do about where I am and where I live and where I work? And I purposely put this sort of hospital room because, again, I really want us to be aware that this isn't about great sweeping things that we need the CEO or the president to do for us. That's great, and that's part of the answer, right? We need structural change, but we also can do things every day in the spaces that we work in. Most famously, as if the physician would sit on the bedside and look the patient in the eyes, right? The patient feels more seen and heard and comfortable. But it truly is those tiny, simple acts of kindness that start to make a difference. We were talking to my hospital recently. They talk about that 5-foot rule or the 10-foot rule of, making eye contact and smiling. And I don't know about you, but through COVID, I think our willingness to look at people in the eye and smile has really drifted. And I mean, you couldn't really see the smiles except for like looking for the creases in the eyes. But we're maskless largely again, and remembering to smile is probably one of the simplest and biggest things that we could do. And at that 5 or 10 foot space, not at 20 or 50 feet, but at a space that is intimate enough that it matters, that you've seen someone, you've recognized them, and you've shared a little bit of human intimacy with them. So trauma mitigation, and again, right, I'm using these words all kind of fluidly: toxic stress, trauma, burnout. So whatever resonates is probably the one to use for you and your environment, but it's about consistency, safety, and stability. That consistency really can be driven by collective standards around reliability and harmony. Safety, about feeling protected, unlikely that there will be danger in my space, and that when I go somewhere, when I'm in a space, that it's unlikely that I will be injured. And that can be, again, physical or emotionally injured, right? That's a lot of the work of inclusion and diversity, is how can I show up in a space as myself and know that somebody isn't going to ridicule or verbally harm me because I showed up as who I am. And then stability, which is a state of continued regular success, consistent experience, and maintaining constant results. And so the administrator in me wants to say that stability looks like patient satisfaction scores, right? If top box patient satisfaction scores are that every time I show up to your hospital, to your practice, I have a branded uniform experience where I feel respected, I feel safe, I feel like I receive the best care. That is like the definition of stability. So again, there's the individual and there's the office-based, there's the entire hospital, and then there's community and country as we think about these frameworks of consistency, safety, and stability. To bring that towards Maslow's triangle, right? We know this inherently, we understand this, that most importantly, at the very bottom of the triangle, we need our physical needs met in a consistent, stable, and safe way. The food needs to not be poisoned. The roof needs to be over my head so that I don't get taken away in the monsoon, right? And when I'm a child, I need an adult there who's consistently serving my needs. It's who we are as people, absolutely craving this consistency, safety, and stability. And the reason we crave it is because it drives the most consistent brain health, the most consistent healthy organism, and everything follows. All of our physical ailments follow from our mental and physical emotional stability. Other, higher orders of that, obviously similar to that brainstem model, is you get to a place where you thrive, right? Where I know that all these basic needs are met. I have safety, connection, and confidence in my environment, and now I'm able to thrive. I'm able to act in my executive function. I know I'm throwing a lot at you, but I really want to try to connect it in a way that it is universal, but it's also incredibly specific, and it's something that we can do with ourselves and on ourselves. So same kind of verbiage, regulate, relate, and reason, this is connected again to that brainstem to cortical functioning. So first in the regulation, that most basic is name it, identify it, understand, be able to unpack and call it out. What is bothering me right now? I've been having a lot of dynamics with my family recently, and I've been struggling to be in my cortical, my frontal lobe and those kinds of executive functioning ways. And what I most recently realized is that I don't feel like I'm trusted. There's lots of checking, lots of asking, and I spend a lot of time doing really important things in a big hospital system, and I'm trusted by my workplace and my colleagues. And when I come home, I don't feel trusted, and it immediately turns me into a whiny 5-year-old, puts me right down into my brainstem. But being able to understand that it's about trust gives me agency to say things that are more communicative, more transparent with my family members, to try to understand, why don't I feel trusted, and is that their intention, right? So it helps to move that conversation along. The regulation helps to contain the impacts of trauma. You're able to champion organizational strengths, and you can implement healthy boundaries. So really being able to manage around what is it and how do I manage it? How do I control it and contain it? What do I say no to? Incredibly important. The relating piece is kindness, compassion. It's modeling that behavior. It's being intentional about smiling, about being kind. It's about being intentional about using language that doesn't hurt others. Oftentimes we do this in humor. Oftentimes we do this in fatigue and humor. A lot of it happens in hospitals and operating rooms because it's the way it's always been, because it's the way it's always related. And one that I'm particularly sensitive to is, I don't know how to pronounce your name, so I'm just going to call you K, X, Y, Z, whatever, right? And people have done that behavior as a way to offload their own discomfort for many, many years. And we have this opportunity, again, as physicians and as leaders, to say, I don't immediately understand how to pronounce your name. I want to get it right. Will you give me the grace and the compassion to allow me to keep trying until I get it right? You can use whatever words you want, but leaning into our own discomfort to make other people feel seen is really an important piece of the relating and the relationships that help to drive stability. And then finally, in terms of reasoning, engaging in focused analysis, offering opportunities and frameworks for meaning making. Why is this happening? How do I talk about why is this happening? What words do I use in my organization, in my workspace, that are safe words to say, I don't understand where you're coming from. I need some help to understand, but I want to be supportive of you. Those kinds of things, inviting people into what you might be feeling as concern or chaos, and creating those safe spaces are our opportunities. And so most importantly, and as I sort of conclude my comments, it starts with me, it starts with us. And sometimes that's the most bitter pill to swallow, because when you feel bad and you feel tired and frustrated, you just want to keep acting out because it's soothing, it's comforting, it's what is the easiest thing to do. And I've often said, when various administrators have said, you know, how difficult doctors are and how frustrating they are and, you know, difficult to deal with, et cetera. And I say, honestly, we're kind of like cats at the SPCA. We've had a really hard road and we're really spicy in the cage. But if you just take us out for a minute and hold us and rub our bellies, we're actually pretty good people. And I think it's sort of, in a nutshell, is the visual image, right? Like the animals at the pound most oftenly are really incredible animals once you can get them home, but they've been through so much that they don't know how to act except in defense. And when we think of the pile of things that physicians in our profession and just trying to heal the world, what we're up against, it is completely overwhelming. And really all you want to do is just protect yourself and keep your heart and your breathing going, keep your core family intact. And so we are way down at the bottom of the triangle right now, collectively. This is another analogy that I've used and I like, because so much of self-care, right? So this is where I tell you just do yoga and it'll be fine. So much of self-care feels like it's a call to drop out, right? Spend hours, you know, breathing deeply, thinking big thoughts about the world. Narrow your practice to be something that only takes care of Botox or only does X, Y, or Z, right? There are many, many ways that we can drop out of the race, if you will. And so that open-hearted, I want to take care of people in the specialty that I chose, and all people, whoever shows up to me, gets these walls around it. Well, only if you have this insurance, only if you have this diagnosis, only if you come from this zip code. And we do it, right? I've bounced 4 different jobs in my 13-year career, 15-year career so far, in part because I've not known how to create boundaries and shelter in place. So what I like to say is, you know, to be a juicer, to be the person that's got all the loveliness and the singing bowl and the yoga pants, you need kale growers. And practicing physicians are the kale growers. And so this is about tools to shelter in place, to continue to work, to continue to heal. And simultaneously, if you have or need to make decisions about controlling your practice, I no longer operate. I can't operate and be a good mother. I just can't. But I can be a full-time CMO and try to heal the community around my hospital. I can be in organized medicine and try to be the president or the chair of the AMPAC, leading advocacy for our nation's doctors. I can do those things. And so I've redefined what healing means to me, even though I went to medical school, to have it mean taking your gallbladder out, as an example. So it's about redefining and getting comfortable with who you are and what your healing space is, and it will evolve over time. So really practical next steps, some big, some small. It's for yourself. Educate yourself, read up on some of this stuff, listen to Audible, you know, click through some articles, Google it, some of these terms. Find out what it is and what people are talking about, and be curious, be open. Don't assume you know all the things, and understand that the journey from burnout and hurt and trauma to something that looks more healthy and like an executive functioning leadership, there is a lot of pain and a lot of reckoning that happens in there, because you've got to think through and understand and break some of your habits to be able to show up differently for other people. Once you've educated yourself, educate your leadership, your local leadership, your administration and healthcare. Work on your own personal management. How do I show up in these spaces, and how can I do it in a way that's more true to who I want to be in the world? For self-care, find a hobby, you know, and take those steps to heal. What I'll say here is that because most of us are physicians, we are highly goal-oriented, excellence-driven people. And so if I'm going to run, it's going to be the Boston Marathon. If I'm going to paint, it's going to be a Picasso, right? If I'm going to play the piano, it's going to be the most beautiful Chopin ever. But that's not practical, and it's not necessary. So if I'm going to run, maybe it's just to the end of my driveway. But it's something that I do for me, and I take a moment of pause and intentionally break the cycle of the madness and go do that. It could be walking the dog. And for me recently, I have an iWatch, and so I've committed to closing all 3 rings every day. And some days it's just sitting with a water bottle going like this until mercifully the rings actually close. But other days it's going out and playing soccer with my children, or it's agreeing to be a soccer coach with my children. So there's many, many ways to find those hobbies and bring those back into your life. And for those of us that are getting closer to what might be a retirement age, so many physicians do not retire well. A lot of that reason is because we've given up everything except our healing personality. And so starting today to find and grow a hobby gives you personality and persona that isn't connected to the act of actively healing in front of a patient. And it is life-saving. It is also profession-saving, because I will say, as a mid-career physician, I am desperate to find examples of physicians who retire well. I want to know what it is, what the path is. I want mentorship to know how to do that, because I don't want to die with my boots on. It is impossibly hard to find people who have transitioned to love their life, still be a healing entity in their community, but not have to show up to work every day to feel fulfilled with their life as a doctor. As far as modeling, be the person you want to see in the world, even if it doesn't feel authentic, even if I'm super crabby and grouchy. I try to show up and smile. I try to show up and be kind. It's not perfect, but I practice the act of showing up as my best self as part of my modeling to lead in this environment. As it relates to our environment, I put the little baby kales there, right? Because being a kale grower doesn't mean that you've got the big flourishing field. Sometimes it just means a pot with a little seedling. So be worthy of followership, right? Just because we're named leaders because we're docs, or maybe you're the chief of staff, people don't have to want to follow you. I think as Americans, over the last decade, we really understand that just because you have a title doesn't mean that people want to follow you. So be worthy of that followership, even in those small moments, those eyeballs in the OR. Make it so that more often people are smiling because you walked in the room, not sort of hiding their eyes and walking the opposite direction because, oh no, Dr. Buckley's here yet again. Try to show up as your best self and define the processes and gain buy-in, and then be accountable to those processes. So it is easier to show up as your best self if you have regulated your space. So for example, your office schedule. If I say I want to see 20 patients a day, and every day we add 3 into lunch and 2 before it's supposed to start, we double book the afternoon, and then we add 2 or 3 in the late day when I'm supposed to be going, out on a date with my significant other. Every single day is going to be disappointing and frustrating. And it is really hard and sometimes impossible to have the discipline to block your schedule. But as I hear colleagues of mine calling and saying, I am so spun so far, I can't do this. I'm going to change jobs. I'm going to quit. I'm looking to leave medicine. I'm getting a coaching certificate so I can go into coaching and retire from clinical medicine because I just can't take it anymore. That is the real tragedy. The ask to do not put anybody in my lunch hour is a much safer ask for our communities and for our profession than the 2 years later dropping out altogether because you didn't feel empowered to be able to make those smaller steps to begin with. And again, you've got to start small. And that first creation of space may be something as simple as 1 patient one day, right? 1 ask, but it becomes a much more structured process over time. And then you can show up having whatever's going on in your personal life, but your day is regulated such that even though you may be sitting more closer to your brainstem, that you show up as a leader looking like you're in your executive functioning, if that makes sense. The more stable the environment is around you, the less personally great you have to feel on any given day to show up and do your job in a way that patient experience, as an example, is perfect, right? I want my patients every day to think that I am the best, safest doctor and facility that they could possibly be at. But I can't possibly expect that every day that myself and my nurses are going to show up all popcorn and unicorns, right? So if we create this structure, we're not begging for overtime every day. We know how the process goes. We know when rounds happen. We know when the discharges happen. And we strive for that. We create that structure that allows us to take a little bit of that inflammation out of our brain and out of our system. That about covers that slide. And so, finally, there's lots of places to read. These are 4 of my favorite books right now. This is the article that I referenced. You just have to Google 9 executives, Shanafelt, Mayo. It'll pop up as a PDF. I can never remember what it's actually called, but it's all right there for you. And they really just define, again, not in a really medicine-y way, but in a human way, what are we talking about when we say that if we just constantly expose ourselves to this unmitigated stress, the expectation that we're going to show up as really excellent, trustworthy people, it's a crazy expectation. We have got to figure out how to manage the stress in the small ways, to grow it into bigger ways, to be able to eventually turn this tide and change the culture. So I thank you for your attention. I thank you for the opportunity to speak with you. I'm happy to engage in any conversation or any, questions or even challenges to this. But I am so thoroughly convinced that we have this incredible moment right now to lead and to redefine our profession. And I'll leave you with one last really quick story. So at this point, again, not right in my bio, but my oldest is 10 and my twins are 8. And most of you have known me since before I even had those people. But one of my twins asked me about a year ago, "Mommy, did you become a doctor because you knew COVID was coming?" And while I felt really honored that he thought I was that smart and that good, I spent a little bit of time kind of considering that. And no, I did not choose medicine because I knew a once in 100 years generational pandemic was coming. But for some reason, the universe chose us to be healers, to be leaders, to be community leaders, family leaders in this moment in time with the most social and infectious and medicine and justice upset upheaval that anybody in 100 years has known. And so we have a tremendous opportunity to literally touch everyone on this globe as healers to help walk through and set the stage for the next 100 years. That is a tremendous, tremendous responsibility, but what a completely awesome opportunity. So with that, thank you very much.
Well, thank you, Dr. Buckley. That's absolutely amazing amount of information. I think, resonates with everybody listening. We have a couple of folks who'd like to make some comments. Dr. Rusinowitz, I think you're the first one.
Well, I just want to thank you, Brooke. I mean, that was not just a home run. You knocked it out of the park. It also made me think of, doing the work I do and trying to get physicians' attention as to what's going on in their lives. And maybe I'm biased because I'm a neurologist, but in seeing your model of the brain and the cortex, I really think that most people that become physicians are very high powered in the cortex and the rest is kind of lacking. I mean, some people play football, some basketball. I think we strive in the cortical functions, and that's tested and nourished to get into medical school, to get through medical school. And then when you become a resident, things are a little different. But I think most of the docs we see have weak limbic systems. They don't process emotion, but give them a task to do and they'll do it. And I thought there's a show on television, The Good Doctor, about a doc who is in the autism spectrum. And I watch it, he's brilliant, but he doesn't have patient interactions. And now when I watch that show with my wife, he acts like half the doctors I've met, and they don't have autism. They just cannot relate to people because they've been so trained and inbred for their cortex to shine. And I think that's one of the greatest obstacles we face when we see physicians who have other problems. So thanks for.
So I love that comment because, again, really just trying to understand who are we and how did we get here. I think about as soon as we declare we want to be a doctor, and it's like doctor, lawyer, pope, whatever, society gives us a pass. You're going to be a healer, so therefore you don't really have to be anything else. You don't have to be charming. You don't have to be socially effective. You don't even have to show up on time or park in one parking space. And quite frankly, you don't have to drive the speed limit because we'll let you go, doc, right? And that's changing, but we are actually trained to not be kind. Trained to not think of others. And if you think about internship and the molding of young doctors, it's about disconnecting, disassociating from the humanity. And quite frankly, on my chief year in 2007 when a kid slammed his car into a tree on St. Patrick's Day. And we lost him on the CT table, which you should never have a patient like that in the CT table. And I walked my junior resident out the back door so we wouldn't have to make eye contact with his mom. The only thing I could think about was that the CT tech had thrown a towel over my green clogs and I didn't get blood on my shoes. And that, when they called us in to meet with the nurses, because the nurses were freaking out and had to go home and all the things. And as a chief resident, all I could think of is you guys are weak and thank goodness I didn't ruin my clogs. And thinking about that 20 years later, it's embarrassing and it's sad that that's where we take ourselves to function as doctors. And it's taken years to try to walk back from that attitude. And I totally get why we have to do some of that, because some of the work we do is truly non-human in terms of how we have to relate and come back in. But that realization that we just have to be imperfect people doing the best we can to journey with people in their catastrophic and health circumstances is a place that as a profession we've got to get our head around. And so that's part of the opportunity and the challenge of our education of each other, really, is how can you do this work as a person and be a excellent, highly trained, highly skilled, take the body of work seriously physician. So I totally agree with you. It's a huge challenge.
Dr. York, I believe you have a comment that you wanted to make as well.
Oh, thank you. And thank you so much, Brooke. This has been just an excellent presentation. There's so much to it. And then even these last few comments, I'm like, oh my God. Yes, I resonate that. I remember working on shock trauma and dealing with all that stuff and just being totally, and it takes such a long time to work through that. And, being older in my life, I can be a little bit more spontaneous with patients, but it's taken a long time, but I still need to work at it. One comment I thought of too was that the whole concept of providers. Oh, the providers are going to do this. The providers are going to do that. We're doing this with our providers. I never remember going to provider school. It's very much a put you in a box and depersonalization type of thing. Whether, you're, no matter how highly trained and experienced you are, you're no different than a PA or a nurse prac. And those are wonderful people and they have their training, and we got to have physician-led teams. But as an employee, especially as an employed doc now, it's like, well, those providers, we got to, and we got to do more with less. And it's all over medicine. There's lots and lots of challenges. And it's so hard to, take a breath and think about these things and give yourself a little bit of time and space to lead and not just react and be in the trenches firing your weapon as fast as you can.
So I mean, obviously, because I got to give the lecture, I get to respond to these, which is awesome. And I couldn't agree with you more in terms of the personal insult, right, that we feel, and the sort of emotional trauma that we feel when people clump us as providers. And I'll say I have a complicated relationship with the word provider, because part of me just wants to be an adult and be like, it doesn't matter. It's a word, it's efficient, and it helps. Like the word she and the word he, very efficient words. They don't work for everybody, but they're very efficient, and they put us in categories that make things very simple. So provider, very simple. You're either a licensed healthcare professional or you're not. But it doesn't at all see the individuality and the incredible, almost not beyond human commitment that we have made as physicians to do this work. It doesn't give any honor or any distinction to our families who have stayed with us and lived with us and tolerated us through this work. It doesn't give any space to the things that we've put away and given up on to have the honor to do this work, right? So what you're describing, I hear, is the moral injury that you are going to assault me with your words and cut me down to be a provider for all that I have given up to do this. And so when we are in a hurt and harmed space, provider really hurts, because you're like, golly, you have no idea what I've done for you. When you are in a kind of executive functioning space where you're like, I hear you just using that word because it's efficient and don't feel like it means anything. And right now it doesn't hurt me because I'm totally good with who I am and what I do in the world. And so what I've kind of landed on recently is physicians and other providers. So the efficiency, when I first started writing my CMO newsletters, right, I'd be like, dear providers, right? Because it's super complicated and clunky and extra words to be like the doctors and the PAs and the NPs and the midwives and all the people. And I got called out pretty hard by a couple of family medicine physicians in my environment. They're like, what are you doing? Like, you're a traitor. And so in trying to settle with that, I do think that physicians are distinctly different than all other licensed providers, and that it's really important, not in an antagonistic way, but in an informative way, that we remind people that it's physicians and other licensed providers. So that's where I'm at with it.
I like that.
Well, I have a question. I'll try and limit my question because your talk brought up so many thoughts about what we do. But I was wondering if you had, what thoughts you had about what institutions can do to facilitate physicians being aware of the feelings they have, and how they might utilize those feelings from change them from being overwhelmed to productively doing something about what they're experiencing and doing something about the situation they're in, which is often being overstimulated and being in impossible binds.
No, absolutely. It's a great comment. And I think it's one of these both and situations. There is a lot that we can structurally, using, common language today, that we can structurally change to support the work of the physician. And then the sad piece about being in the messy middle and in the journey is that it's not going to happen overnight. And so we have to learn to regulate ourselves in a completely messy environment. So structurally speaking, and that's why I love Shanna Felt's article, there are things like safe spaces. So for example, a physician lounge that is accessible, that has a proper lighting, enough computers, has nourishment that is reliably available, those kinds of things, which is predictability, right? It's structure, it's consistency, it's mental safety, that when I go into this space, that it's only going to be the people that are supposed to be in this space, which means that I can talk about what I need to talk about, and that I can receive what I expect to receive in terms of nourishment or whatever, right? So however you define that space, it's having that space be reliably and predictably available, and having it be sufficiently outfitted such that it doesn't look like it was an afterthought and they just threw you in a corner. For some people, that hill to die on is the physician parking lot, right? Like, how dare you let APPs in my physician parking lot? But it's really about, when I get here and I'm frazzled and I'm on call and I'm racing in, I have to have a place to park. Like, please respect me enough to have a place to park. And that's where I talk about, us creating our own particular boundaries. So if I don't, as a surgeon, I don't like getting harassed when I show up in the morning because I need to be in my mental space to take care of this patient, then I'm going to commit to showing up a half hour before the first start of the case. And I'm going to work with the nursing and anesthesia staff to say, you have a half hour with me to get this work done. And here's the structure of how we're going to get the work done. But like, when we get 5 minutes in, I don't want all this crazy hysterical stuff because I need to be in my zone. Nothing works perfectly 100% of the time, so please don't misunderstand what I'm saying. But if I always show up at 7:25 for a 7:30 start, I can expect that those 5 minutes are going to be out of control every single day. And so it's creating buffers and zones personally, and then advocating for those as a medical staff, for example, or as a leadership group of a multi-specialty group, or however you work. And then it's asking for those types of reasonable things from your hospital administration. So for example, hospital administration don't plan meetings for me as a private practice, single physician, there you go, at noon, right? That doesn't work for my schedule. I need it at 7 or I need it at 5 or whatever it is that you need it. But for instance, what we often do is it's always at noon. I always miss it. Then I get a slap or a letter about not showing up, and then I lose my mind and show up at the president's office like, this is ridiculous and I'm not participating anymore. And so that's sort of the bad way to handle it. The good way to handle it, I always say, take it out of the patient room, right? We tend to just get frustrated and like lose our minds in front of patients. If we can stay and do the right thing in front of a patient, and then whether it's the RL solutions or pink slips or however your workspace reports things that went wrong, look for structural things to fix so that the same scenario doesn't happen the next time. There aren't easy answers here, and we are so far off from something stable. But I will also say, and this is sort of putting on my political action committee advocacy hat, is that the hard work is educating myself, spending the time lobbying, talking to politicians, making those relationships. Simultaneously, if I pay for organized medicine, or I pay for a PAC, or I support my CMO and lean in with reasonable information, tidbits, and financial support, those are the armies of people that are doing the work for you. Lobbyists at the AMA do the work for us on Capitol Hill to get laws passed that make sense and structurally support us about prior auth, Medicare reforms, and other things. And when we don't join our state societies, our specialty societies, and our national societies, we lose our voice. And then we have to do more of it ourselves every single day in our work. And again, not a perfect translation, but it's really something to think about as we try to recruit others into these organizations, is that we cannot do it all on our own. And we have got to pay the experts, the lobbyists, and others to help us with this body of work.
Any other questions or comments?
See, Dr. Allen has his hand up.
Ah.
He's on my screen.
Dr. Allen, you're on mute. Can you unmute?
That was a wonderful presentation, and I certainly endorse some of the references that I know that you cited. And I think actually getting involved in the medical society is a very good thing to do, because it gets you away from it gets the doctor out of his space in his office or the hospital or wherever, and gives you a chance to kind of interact with other physicians, many of whom are struggling with some of the same issues and have some solutions that you didn't think of. And so that's always very helpful. When I was a medical student, I was in medical school at Columbia in New York, and the local medical society was very much devalued by the professors. And it wasn't until I got out and got into practice and got into the real world that I learned how valuable it really is. So I certainly would encourage people to get involved. It is a great way of breaking that kind of demeanor of being always having to be the perfect doctor and do everything right.
Thank you. I'll just add to that. I think the deserving followership, the medical societies really struggle sometimes for membership, and it's demonstrating the value that deserves followership. There's clearly practical issues of just like, I don't have another $500 to give. And it's about how we prioritize things that matter. And I think as we're coming out of COVID and in this big questioning around big data, augmented intelligence, partnering with computers, do I stay with telemedicine or in person? Do we go for Zoom meetings, or do we actually, how much more rich when we're all in the same room, right? This works, we pass information, but there's something missing. There's a three-dimensionality that's really missing. And I think that, state medical societies and other places allow us that pause to really truly connect in ways that are deeper and more human. And so again, just getting curious about it and being jealous of our time with each other to connect. And so the last thing that I'll share on all of this, the easiest thing that any of us can do is to invite each other to tell our stories. So there's lots of generational disconnect. There's lots of licensed provider disconnect. There's lots of just questioning about who are you and who am I and how do we fit into this space. And I think I used to use working nights as my opportunity to practice asking hard questions. I don't really understand this about you and your situation. I don't even have the right words to ask the question, but can you help me understand? Can we take 5 minutes and can you just describe to me? And so I think that most simply, if we start asking questions, we'll find more similarities and it'll start to help us walk down that path. And we'll look back and say, oh, wow, I'm doing these things. I'm deserving followership. I'm being kinder. I'm smiling. I'm being nicer. I'm showing up as a better person. I'm setting more realistic boundaries because I'm talking to people and we each know what works and what doesn't work. So if you take one thing away from this, you know, ask somebody about their story and their path and their profession or their life, because I think that that's where we really start to evolve to a new space. So thank you so much.
Thank you. Thank you very, very much. Just a couple of housekeeping points before folks leave. For anyone that was on the Zoom tonight, you will receive an email probably tomorrow, worst case scenario Monday, with a link to the evaluation, and that's how you will get your CME. So please look for that. If for whatever reason you don't get it, or if you would like the PowerPoint or recording of this presentation, email us at phpinfo, I-N-F-O, at medchi.org. I did put that in the chat, but you know, please keep that. That's also a good email address if you have any questions, if you have ideas about who you would like for us to invite to speak in this series. We would love to hear from you and from feedback from you. I've actually gotten a couple of emails, and Dr. Buckley, you just hit it out of the park.
Oh,
Everybody thinks it's excellent. So thank you so much. I'm also going to make, you know, I guess a plea/reminder. If you can donate to MPHP, our 45th anniversary, we would really appreciate that. I also put that link in the chat. But if you don't get it and you need it, email us. phpinfo@medchi.org, and we'll send it to you. But I want to thank you very much. This has been an excellent presentation tonight. I think it's given everybody a lot to think about.
Thank you.
So thanks very much to everyone. Have a great rest of your evening. And again, any questions or anything, please let us know.
Thank you very much. This is awesome.
Thank you.
Thank you.
Thanks, Brooke.
Absolutely. Thank you. It's good to be home.
Very much.